Welcome to the Tick-Tective Podcast, a program of the Bay Area Lyme Foundation, where our mission is to make Lyme disease easy to diagnose and simple to cure. I'm your host, Dana Parrish, and I'm the co-author of the book Chronic, and I sit on the advisory board of Bay Area Lyme Foundation. This program offers insightful interviews with scientists, clinicians, patients, and other interesting people. We're a nonprofit based in Silicon Valley, and thanks to a generous grant that covers 100% of our overhead, all of your donations go directly to our research and prevention programs. For more information about Lyme disease, please visit us at bayarealyme.org. Today, I welcome Dr. Scott Commins. He is a highly esteemed expert in the field of allergy and immunology at UNC and a pioneer when it comes to alpha-gal syndrome. Now, alpha-gal is that thing you heard about when a tick bite can cause a meat allergy, but there is so much more to know. So enjoy this interview. I hope you learn a lot. And please share it with your doctors because there is such a lack of education about this very important syndrome, and doctors becoming aware of it will only help us patients. Thanks for joining us today. I'm so excited to meet you finally. It's been so many years that I've been hearing about you and the legendary work that you do and all the patients that you help with alpha-gal syndrome. You are the #1 expert in my world. So thanks for everything you do. I just heard something so cool about you. I heard that you now have the professorship at UNC, William J. Yount. And who was he and what does this mean for you?
Very exciting. Just happened within the past year. When I came to Carolina about 10 years ago, they put my clinic on a Wednesday, and turns out that's the academic day here. So there are very few people seeing patients in the allergy clinic, but the one other person at that time was Dr. Yount, and he was the founding faculty member of the rheumatology, allergy, and immunology division at UNC. And he did this amazing basic science work. And in sort of this full life, like full circle moment, one day Dr. Yount and I were chatting between patients, and it turns out that he had been in London training on a new technique that was taught to him by my mentor, Dr. Tom Platts-Mills, who was the senior person in the lab in London at the time. Wow. And so it was really this kind of amazing moment where I felt as though my two mentors had connected. And so holding the Yount professorship is incredibly meaningful to me.
Congratulations.
Thank you.
If you don't mind taking us back to the beginning, because I know some people will have a little burgeoning awareness of what alpha-gal syndrome is, but in listening to your talks and reading things that you've published and written about, I have been shocked at really what alpha-gal can do and what it is. So if you don't mind, just what is alpha-gal syndrome?
Right. So alpha-gal syndrome, which I will probably call AGS, and I can tell you why I really feel strongly that we consider it a syndrome. But at its basis, the alpha-gal allergy is really an allergic response to a sugar. And the sugar is galactose alpha-1,3 galactose, which we abbreviate alpha-gal for short. And it's a really interesting sugar scientifically because as humans, we don't have this sugar. We have a premature stop codon in one of our genes that would make this sugar, but it doesn't. And uniquely, all lower mammals, so non-human, non-primate, right? Cows, pigs, cats, dogs, all non-human primates have alpha-gal. The immunologists have known about this sugar for a long time because we as humans make a response to it. We don't make the sugar, we make an immune response to it. And it is the reason that if you were to say, put a pig liver in me, I would hyperacute reject it is what they call it. So we have all these antibodies directed against alpha-gal. And so the transplant surgeons have known about it for years. But what makes the alpha-gal syndrome unique is now we're talking about people who've developed an allergic response, not an infection fighting response, but an allergic response to alpha-gal. So when they eat red meat, like beef, pork, lamb, venison, rabbit, etc., non-human mammal meat, then they get an allergic reaction. And
Huh.
it's the typical, it can be the typical kind of allergic reaction where you get hives or itching or swelling, shortness of breath, chest tightness, lightheadedness, right? We think about anaphylaxis. You can have that with alpha-gal syndrome, but uniquely, it's delayed. So you eat a burger or a hot dog for dinner, and literally nothing happens for hours. 3, 4, 5, 6 hours later, you start to itch, and then it progresses from there. So it is unique in a lot of ways. It's a sugar, and almost everything else about allergy is based on proteins. And the reactions are delayed, so that makes it tough to diagnose. And it changes when we figured this out, it really changed the paradigm for food allergy, because typically you would tell someone, look, if you've made it to your teenage years safely eating a food, you're probably good to go. Your immune system has seen that food countless times. It's not making an immune response. Yes, there are occasional episodes, I would call it rare, of adult onset food allergy, but that does occur right to seafood we hear about. But we really haven't seen like these massive numbers of people becoming allergic to a brand new allergen as an adult, like we've seen with AGS. So it has changed that paradigm of once you tolerate something, you're good to go. It really has flipped a lot of our conventional food allergy sort of rules, if you will, on their head.
So where did this originate? When did science first discover this happening?
Yeah, the origin story is kind of long and unique, I think, but basically in the lab of Dr. Tom Platts Mills at the University of Virginia, his group was working on and investigating patients who were actually in the cancer clinics, and they were reacting on first infusion to a chemotherapy drug called cetuximab. And when you want to get an allergist interested, often it's that idea of a first infusion, right? So these are cancer patients who'd never seen this drug before. And the first time they get it, they're having these allergic reactions. So for an allergist, you start to think, wait, that allergic response is already there. It's not something that happened after the immune system saw this medicine multiple times. It was already there.
Because that's the normal thing, right? You get primed for these things, and then it happens. Like you get your first bee sting, maybe nothing happens. You get the second one, and oh my God, my whole face is swollen or whatever.
That's right. Like penicillin allergy, we see real penicillin allergy in patients who receive penicillin over and over and over again.
Yeah.
That induces the immune response. But this was unique in that first infusion. So Dr. Platts Mills's lab, really in collaborating with others, was the place that figured out the patients who were reacting to cetuximab were actually reacting to this alpha-gal sugar that is on cetuximab. It's placed there because they're made in a mammal cell line.
Right.
Yes. And so
and this is a monoclonal antibody, correct?
That's right. That's right.
Okay.
And that's not uncommon for pharmaceutical companies to make these monoclonal antibodies in like a production cell line. That's the usual business. But this just happened to be one of those instances where the cells actually put a lot of copies of this alpha-gal sugar on the final version, if you will, of cetuximab. And so patients were reacting on initial infusion.
How many?
Probably the UNC experience was pretty heavily documented, where they started a clinical trial, and the first two patients that they gave cetuximab to both reacted. One had severe anaphylaxis and I think ended up needing to go to the hospital for further treatment. So it was happening at a rate in some places, and that becomes key. In some places, probably in the 20 to 40% range.
Wow.
But there were other places, Boston, California, where it wasn't happening at all. And
Oh,
so,
that's so interesting.
yeah, so there became this sort of geographic portion to the story as well. That became a paper in the New England Journal.
What may have been happening was that they were actually primed and they didn't have any symptoms. And then they got this second hit and it was like, oh gosh, I might have anaphylaxis. And
That's right. But we didn't
That's-
know anything at that stage about tick bites. There was no sense of red meat allergy or the whole AGS thing. It initially started as basically a drug allergy. And then right on the heels of that, and Dr. Platts-Mills's group figuring out, wait, these patients all have an allergic antibody that recognizes this alpha-gal sugar. Around that same time, then I join his group and we start to hear from a very few number of patients, I think I might be allergic to beef, but it's weird because it
it's
doesn't happen.
delayed.
It doesn't happen every time. And then I was worried about beef, so I cut it out. And now I think it's happening to pork. And so basically, what the patients end up describing in the allergy clinic, mind you, not the cancer clinic, but in the allergy clinic, was that they were allergic to mammal meat. We were fortunate that his lab had been thinking about alpha-gal already. So it started to make sense. Like, wait, could the distribution of this alpha-gal sugar explain what these patients are telling us in the allergy clinic? And his lab happened to have the test because they've been working on it for the cetuximab story. As you might think, like, just draw some blood. Let's run these meat allergic patients' blood test for the alpha-gal allergy and see what happens. And sure enough, they were positive. So
Wow.
it's sort of really, I think, in many ways, a serendipitous story. I think we probably would have figured it out. My sense is that we figured it out much quicker because of what Dr. Platts-Mills's group had already been doing. When I land in his lab, basically that becomes my project. That is this idea of, hey, doc, I think I could be allergic to beef, and then sort of explaining it from there. So in 2009, we published the first report in the US, just 24 people, 19 from Central Virginia, 5 from Southern Missouri, all test positive by blood test for alpha-gal IgE, which is the allergic antibody. And that was a report at that time. We had not really formally challenged them in a, like, come in, eat red meat, let's see what happens kind of thing. So it was just the report. And that was 2009. And it really has basically just continued to expand and widen since that time.
Is this still happening with monoclonal antibodies or any other biologics?
I think the short answer is it's basically not a concern. I think the pharmaceutical companies have learned now to screen for some of this stuff that happens after basically the sugars kind of go on last. And so they sort of screen now for what happens at the end. And I think, I mean, it could happen again, sure, but I think it would be really unlikely to see this kind of story play out again, is my sense.
Interesting. So the most common way that people are acquiring alpha-gal syndrome is through tick bites. It sounds like that's what you're saying.
Yes, that we had no knowledge of tick bites as all this started, but as you fast forward, correct. We've now established that both in mouse models in the laboratory and then in a case control study with the CDC, that tick bites are the risk factor or are a risk factor for developing alpha-gal syndrome. In the US, the tick species of most concern is what we call the Lone Star tick or Amblyomma americanum. It turns out alpha-gal syndrome is worldwide. And in each of these, to me, it's fascinating that in each of these places where there are hotspots, Europe, Scandinavia, Australia, South Africa, there are ticks, and there are different species of ticks in these places. So in the US, we worry a lot about Lone Star ticks, but it's not at all just a Lone Star tick phenomenon.
First of all, is the prevalence becoming greater? And are there geographical hotspots specifically here?
There are hotspots here, particularly kind of the middle southeastern states, but now, so that I would think North Carolina, Virginia, Tennessee, Kentucky, Southern Missouri has a real problem with this, Arkansas as well. But now we're really seeing an explosion of cases up the East Coast. In the paper in 2013 that we did with the CDC and VeraCore, we looked at all of the positive cases, positive blood tests, I should say, in the US up until 2022, and 4% of all positive testing was coming out of Suffolk County, Long Island.
Oh my gosh, I don't go there anymore. Even if you are the most careful, like me, I walk on the stones in the center of the sidewalk. I mean, I got a tick bite walking into a restaurant that through cobblestone, through big stones. There was a couple blades of grass, got me on my toe. I'm just saying, it's like so hard to avoid. I mean, it's almost like, are we being punked? There are this many billions of ticks in this area. It's crazy.
The story in the Hamptons is really fascinating and incredible, but you hear similar things from people that live in northern Arkansas and southern Missouri.
Yeah.
The amount of ticks is just incredible. So we're seeing, up the East Coast, but now there's movement of this, or awareness, or just cases of AGS being found in the central US, and even some cases sort of headed toward the Great Lakes area. And, so there are hotspots for sure. And you asked about prevalence. We and others are working on that, but I can tell you from just taking care of patients, I have some people who come in and will say, look, I think I've had this for years. I was finally diagnosed. I will equally have people who come in and literally were diagnosed, or we diagnosed them within 4 to 6 months before. So new cases are still emerging, absolutely. And then there are these kind of more historic cases as well who are just kind of now coming to awareness. So it is a mix, but it's certainly not all this retrospective idea.
It's just so weird, right? I mean, it's just I always, when we wrote the book, I just remember thinking about alpha-gal. Like, everything else seemed sort of straightforward and I could get a handle on it. Alpha-gal was just like, what? Because the first few years that I was in the Lyme world, I thought it was an infection. I didn't even understand that it was this whole other entity unto itself. So it's so fascinating. I'd also be curious if you could tell people, what does a Lone Star tick look like? Because I know they have identifying features, but could you send it into a lab before you get diagnosed with it? Like we do with Lyme and Babesia, Bartonella, those kind of things. We send them into labs sometimes to find out what was in that tick that bit me. Is alpha-gal on the list of things they can identify?
Currently, alpha-gal is not on that list. And I think some of this is really that on the research side, from an AGS standpoint, we're, I would say, a decade, maybe two, behind the Lyme disease researchers, because once you initially identify it, then you're doing all of those more basic things that have to be answered, like food challenges, to show that it's really delayed. So we currently don't have the capacity or the ability, I should say, the capability to be able to test a tick, so to speak, for alpha-gal. I think where the data are currently leading us are that most or many Lone Star ticks have the alpha-gal antigen or allergen as part of their, we think, salivary compartment, so to speak.
So that makes tick attachment time very different from what is traditionally, like there's a lot of misinformation around this whole topic of whether ticks can transmit anything concerning quickly. So I think you just said something so interesting.
Yeah, no, we're fascinated by that. So I'm glad you brought it up, because people will often say, how long does the tick have to be attached to me before I should be concerned? And I think at the basis, it may be that the allergic response to alpha-gal occurs much faster than what it would take for an infection to transmit, right? This may be a real differentiator between infection-related or infection-associated tick-borne illness and alpha-gal syndrome, because we're starting, I mean, it's, let's be honest, incredibly difficult experiment to do, right? To ask a patient, just keep the tick on, let's see how long, like you can't do that. So,
Right.
so it's going to be, we're going to have to accumulate this data, I think, from some of our mouse models. But it seems to me that one of the hallmark parts of the story for people who develop alpha-gal syndrome is that the site of the tick bite is red, itchy, inflamed. It's slow to heal. And sometimes people will even say it feels as though there's a hard knot underneath where the tick has bitten them.
That I had that. It was itching for so long, and you could see it for so long that I went to the dermatologist like 2, 3 months later. It was red and itchy, and I had a line going all the way down my arm. It was not cellulitis, but it was this weird immune response. Have you seen that before?
Yes, I think that is kind of like this allergic response that's happening in the skin to some part of the tick, whether it's the saliva or, ticks use cement to attach, or could it be some like factor that is part of they don't have heads, they have what people call mouth parts, right? So for some people who go on to develop AGS, what you described is that initial allergic immune response. And the way I think about this is sort of is like a pyramid where you have to have what you just described to eventually go on to develop AGS. But I think there are a tremendous amount of people who have similar reactions to a tick bite, but never truly develop the alpha-gal allergy. And this whole area is in need of more funding and is ripe for research, because we don't understand enough, in my mind, about the human immune response to tick bites to know when people talk about that skin response that you just mentioned, what does that really mean? And how do we predict from there who goes on to develop alpha-gal syndrome, and could we intervene in some way to be able to stop that? So I think if people get that kind of response, I would ask them to be sort of tuned into that. And the tick itself, the differentiating markings on a Lone Star tick are on the female. So they have a white spot on their back. But to me, the male Lone Star ticks look like any other. I'm not a tick expert. So to me, they look like any other tick, but it's the females that have that white spot. So
are they bigger than a deer? So we know, so just for people who don't know, a deer tick is the size of a poppy seed, often when they're not engorged. They're so tiny. That's why people miss them all the time, like me. Is this tick a little bigger?
It is, but it also has that larval stage where people will talk about seed ticks.
Shudder.
Yeah, exactly. Because, you can get 50 or 100 bites if you brush by the wrong leaf as these hatch. And so I find it incredibly, well, I can't differentiate between those larval stages amongst the various species. So
at that stage, they can transmit?
It seems pretty clear from talking to patients, and we know from the next stage up, which is the nymphal stage in our mouse model. Dr. Shahid Karim, who's our collaborator on the tick mouse side of it, he can sensitize mice. He can basically make them allergic using that middle nymphal stage. So we think probably it goes even to those tiny seed ticks.
That is so fascinating. If people don't know that ticks are the dirty needle of nature, take that away from this conversation. Avoid at all costs. We can talk about that later because there's probably a couple tips that you have for us. In terms of the reactions that people are having to alpha-gal, I'm sure there's a breadth of them. And I've heard you talk. I heard many of your talks. So I know that there is, but I'm curious, what is the breadth and what are you seeing and what do you hear about most commonly in your patients?
Sure. So the most common presentation amongst my patients really is hives and accompanied by gastrointestinal distress. So, I mean, I think hives need no further explanation. They often seem to start, the allergic reactions seem to start for many people with itchy red palms.
Oh,
And
interesting.
then within 15, 20, 30 minutes, they'll talk about some more systemic itching and hives, and then often gastrointestinal upset. So nausea, vomiting, diarrhea, the abdominal cramping and pain that I've had patients tell me, like my female patients will say worse pain, like more painful than childbirth. I've had patients who've had an appendicitis say that the pain associated with alpha-gal syndrome reactions is similar. I think it is the type of gastrointestinal pain that can take adults to an emergency department in the middle of the night, which is, I think, says a lot because no one
Oh,
really
yeah,
wants to go. But
absolutely.
that's the typical. There are patients who talk about shortness of breath. It doesn't seem to come up, the respiratory part doesn't seem to come up quite as much, but certainly lightheadedness, dizziness, which means that your blood pressure is falling. So those things go together to create this scenario called anaphylaxis.
Is it
Yes,
common people have
if you,
anaphylaxis too?
it's, well, keep in mind that anaphylaxis technically means you have two organ systems involved. So if you have skin and gastro, and you've had a likely allergen ingestion, that meets the definition for anaphylaxis. So
Ah,
roughly 70% of people that have AGS have a history of anaphylaxis, which is high.
I thought it was just like the throat swelling. I didn't know that. That's great to know.
Yeah, it's sort of a common misconception, but the the other part of this that we see and are now in tuned with is that some people present with isolated gastrointestinal symptoms. So they don't get hives or itching or shortness of breath, throat closure, any of that. They just, I shouldn't say just, but their presentation is that of abdominal cramping and pain, nausea, vomiting, diarrhea. It often is delayed in many instances more on the 2 to 3 hour mark than the say 4 to 6 hour mark, but it does not seem
Mhm.
to typically happen right away.
It's terrifying to think about you have a hamburger or something and you go to sleep 2.5, 3 hours later and you wake up in this state. It must be so traumatizing and terrifying to know that you're living with this.
I think that part is really tough on folks. And you can imagine if you go to the emergency department in the middle of the night, prior to there being much awareness of AGS, one of the things that we were hearing from patients is that they were being told, well, it can't be a food allergy because you were asleep. You hadn't eaten anything in a couple of hours.
I can't even imagine if that happened that anybody would figure that out in an ER unless they were at your hospital. I mean, honestly, I think it would be very, very uncommon.
Raising awareness is a critical piece of what I feel like I do. And so talking to you is really important because to me, sometimes I think that just getting the word out is probably as big a part of what I should be doing as it is seeing patients and doing research.
I totally appreciate that. There's so much that people need to know, and it's so complicated, but it's also so common. The more we can put this out, the better. And hopefully they'll share it with their doctors and Their family members, a lot of patients, sure you hear this, their family members are baffled by their symptoms because they're so weird sometimes and so disparate. And they come on at strange times and they migrate and they change. And you're told, you must be crazy. But you're not crazy. Infections do this. Many infections can do this. I heard you say something so fascinating about the relationship between alpha-gal reactions and alcohol and exercise.
Sure. In the food allergy field, we have long known that exercise is what I call a bad actor in facilitating reactions. But technically we call exercise and alcohol cofactors, but there are other food allergy syndromes where if you they are basically exercise dependent, meaning and wheat is one of the classic examples in adults. People eat wheat fine and they exercise fine, but if they eat wheat and exercise, they can have anaphylaxis. So we've seen the same thing in the AGS space where someone may have, say, a slice of pepperoni pizza and be fine. But if they've been for a run before and maybe have a couple of beers or drinks with the pizza and the pepperoni, now all of a sudden they have a reaction. And I'm not sure that we have really worked out the mechanism behind both of those, but alcohol is a vasodilator, so you're probably increasing allergen absorption from the GI tract.
Oh, interesting.
And exercise also would cause vasodilation. So the presumption is you're pulling more allergen in through the gut through absorption. But we find, in addition to alcohol and exercise as cofactors, stress, illness, infection, lack of sleep.
I was going to ask you about this. Yeah.
And for women, menstruation. There are these other kind of cofactors that can sort of facilitate the allergic reactions in general.
So in general, would you be more susceptible to even having this syndrome to begin with if you had any sort of immune dysfunction or immune, if you were slightly immune compromised?
It doesn't seem to be. In our group, we haven't seen like people who have trouble with immune suppression or immunocompromised, that they're at an increased risk for developing AGS. So I think that hopefully is like a little bit of good news.
Do kids get it?
They do. It doesn't seem like kids get it perhaps as frequently, or maybe it's better said that we don't have as many kiddos in our cohorts. But certainly children can get it. And when they do, it looks like the adult version, so to speak. They get hives and GI distress. They can have anaphylaxis. It's still the tick bite. It's still delayed. And they report similar frequency of having that sort of 70% of participants have anaphylaxis in their history as well. So they can absolutely get it, and it can be quite young too.
It's really scary. So can you ever, if you know you have alpha-gal, and I want to talk about all the different foods and medications and things that people should be aware of if they have alpha-gal, can you pre-medicate? If you're kind of like, I'm going to a restaurant, it's my birthday, I don't know if there will be some cross-contamination. Can you take Benadryl? Do you always carry an EpiPen? Like, what do you do?
Definitely, we encourage people to have a epinephrine auto-injector, usually in a known spot, whether that's with them. The alpha-gal allergy sort of changes that a little bit because the reactions don't happen usually at the restaurant, so to speak. But typically we are giving folks a prescription for an epinephrine auto-injector, because just with the idea that even though maybe you haven't had anaphylaxis yet, there's always a chance that you could. And so the pre-medication side of this, some people will, as you said, take a Benadryl or maybe even a longer acting antihistamine that's non-sedating ahead of a meal out to try to, doesn't give you necessarily that ability to order what you're allergic to, but you're trying to
Sure.
order the right thing, but you're guarding against cross-contamination, right? Like
Yeah.
you're saying. We have patients who do that to try to minimize any symptoms that could occur. There's a gastrointestinal medicine too that some of my patients will take ahead to try to help with that sort of similar idea.
What is that?
It's called gastrochrome. Chrome is
Mm.
short for cromolyn. There's a version of cromolyn that really seems to help on the GI side of things. And so
Huh.
people use that. The other strategy now is the FDA in February approved omalizumab, which is Xolair, for under a food allergy indication. So some patients are turning to Xolair. It's usually a monthly or twice a month injection that basically binds up the allergic antibody response as a way to try to prevent cross-contamination and accidental reactions as well.
It doesn't sound like we have anything yet, but it sounds like there's some hope coming down the pike. Do you think that's going to be effective at preventing onset of these acute reactions?
Yes, I think after several months on Xolair, it does seem as though it really helps patients prevent these cross-contamination, accidental reactions. And, I think the other part of this is trying to perhaps do trials where we look to see after a tick bite, could we intervene to try to prevent that allergic response from even developing? Maybe there are ways that we can try to interrupt quite early on, but we also feel like we need to understand who do we try to interrupt and how do you better predict who might be at risk for developing AGS in order to target that intervention.
Do people ever avoid these foods for a period of time and then grow out of it? They stop having alpha-gal syndrome. Does that ever happen?
Yes, it does. It can resolve. It does appear that the allergy cells that the tick bite initiates, that they can wane over time.
Mm.
So avoidance of future tick bites during the couple of years after someone develops AGS is critical, we think, for eventual resolution of the allergy.
Interesting. So what are the animal products and the animals that people are most reacting to? When people come to you for their first appointment and you need to educate them, what are you telling them?
Yeah, we talk a lot about the red meat side of it, so to speak, and also the idea that sort of countering that advertising campaign that pork was the other white meat. It is a mammal meat. So beef, pork, lamb, venison, rabbit, like really kind of going through and in some ways listing out the mammalian meats and kind of debunking the idea of the red meat, so to speak. But we often take this very individual. So dairy as a product of cows can bother some people. And when that is true, we ask for them to remove dairy from their diet. And it doesn't bother everyone, though. So not everyone with the allergy has to remove dairy. We also find that sometimes the fat content is very important. And so occasionally people will be able to have small amounts of lower fat dairy, but really don't tolerate, say, ice cream. There are other people who exposure to gelatin, which is often derived from mammals, can bother them. So marshmallows or Jell-O itself, gelatin can be used in capsules. And at the moment, manufacturers do not have to label where the gelatin comes from. So it's a real challenge for patients because you don't necessarily know if your Tylenol capsule has gelatin that could come from a plant, a fish, or a pig.
Are there like sort of safe drug lists? I'm sure they can always change their formulation too, and I've experienced that myself.
There's not a safe list, and mainly because of what you said, that these manufacturers can change the source of the specific particularly the inactive ingredients, and they never have to change the label one iota. And that's completely within the current law and regulation. So just saying on the label that there's gelatin is all that's required. So I have struggled to keep up with a list in many ways because it's just so dynamic, and we don't have the resources to do that. Fortunately, in the past 12 to 18 months, Vegan Med has come online, and they're an independent group of pharmacists who are basically make it their mission to help people obtain vegan medicines. And I think that initially started from an ethical or religious standpoint, but now alpha-gal syndrome patients really benefit from that knowledge as well.
What about wearing leather, wearing wool?
For the overwhelming majority of people, no. Now wool can be an irritant. And so we definitely see people get itchy, rashy from wool. That may even be enhanced in the AGS group. But I do have some patients who report issues with leather, but it's I would say it's less than uncommon. It's rare.
That's good to know. I read a fascinating piece. I'm 100% sure you must have read it too in the Atlantic. And I know also you've been quoted in the Atlantic before about livestock, about farmers having to sell their flocks, not being able to milk their cows or deliver calves anymore because the amniotic fluid is aerosolizing and they can't even they're having reactions to that. Was this surprising to you? Do you hear from some of these people?
Yes, I've heard from them. It was not surprising to me when Sarah Zhang, who wrote that article, reached out, because it's something that we've heard from time to time. And so this is exactly why I think it is best called alpha-gal syndrome, because it affects beyond just food intake, right? These are people's livelihoods and their hobbies, their passions, and they have to completely reinvent that. And the farmers, I have multiple farmers who've had to change the what is on their farm or even sell it. We have chefs and restaurateurs who can no longer safely taste the food that they're making, so they don't feel comfortable making it. They have to change their line of work as well. So no, it really, it's sad when it happens, but I'm unfortunately well aware of it.
I also wondered, does this ever extend to people's household pets?
Yeah, it is possible. Fortunately, when we see it, often it is more of when my dog or cat licks me, I get an itchy spot on my skin where that contact was. I'll occasionally have people say, and these are often, keep in mind, people who have multiple cats or dogs in their home and have a very high dander burden. And they may say that they feel as though they're congested, or have some sinus issues in a way that they didn't before they developed alpha-gal syndrome. But in my experience has not been, I'm now have anaphylaxis upon exposure to my pet. I don't know that I've ever seen that.
When I was growing up, all of us kids that had any kind of allergic stuff would go to the allergist and get shots every week. I actually don't really think they helped. I was allergic to cats, actually, and dust and like the usual stuff you hear about. Is there anything, I did hear what you said about that. It sounds like a monoclonal antibody coming down the pike that could be extremely helpful, and that's wonderful. Is there anything now like that, though, like an allergy shot that people can get to calm this down a little bit?
The short answer is no. We tried using cat allergy shots, thinking that as a mammal, maybe, and cat is a punchy allergen too. So we were thinking maybe that would help desensitize people, but it didn't really seem to work. I think probably there's not enough alpha-gal in these cat or dog extracts to really modulate that. But one of our goals is to create an allergy shot basically for the tick factors, the tick saliva. And the idea there would be to model kind of like what we do for people that may be allergic to bees or wasp, where we can't prevent that initial allergic reaction to the sting, but then we can put you on venom allergy shots and try to prevent any future stings from creating that same allergic risk. And so what we're trying to do is copy that on the tick side with the idea that, look, we think this thing can go away. The biggest impediment for that is additional tick bites. If we can put you on a tick allergy shot that renders those future bites less immunogenic, meaning they don't reinvigorate that allergic response, then hopefully this whole thing could go away for people at like a 3 to 5 year time horizon. And maybe we've now protected them against future tick bites causing it again. So it's a definite goal. We're starting in a basically, in the cell model, in an animal model, because we don't want to expose folks to tick saliva until we know
Sure.
that it's safe.
I'm just curious, we mentioned cats, like why are so many people allergic to cats? What is it that makes it punchy?
The cat allergen is basically uniquely strong. Just in the allergen world, carries properties that make it incredibly efficient at activating the allergic response. And you know this if you have people or friends or family who are allergic to cats. If they walk into a new environment, they may not even have to see the cat, but they'll know like there's a cat here. And a dog is rarely that dog allergy is rarely that strong.
I slept at my best friend's apartment in LA 10 years after she had a cat. And I slept in a spare bedroom where probably the cat spent a lot of her time. And I had a severe allergic reaction 10 years later from whatever
Wow.
was still. Yeah, and it's a very specific kind of reaction. It's like that. You said what you said. You walk into the room, my eyes all of a sudden get glassy and itchy and red, and I start getting itchy. Before I know it, my face is swelling. Like it's pretty intense. And my dad has the same thing. I always wondered, why do we have this intense allergy? And so many people I know have it,
Yeah. It has
can't-
more to do with the cat allergen properties than you or your father or other. It's the cat allergen itself is that unique.
Oh, that's so interesting. So you mentioned earlier, and I know you did an incredible talk on this last week because I've heard many people tell me about it. If we could close by talking about the post-traumatic stress element of having this. I'm actually allergic to Bactrim. And I remember, and it was what you said, I had it many times for UTIs over the course of my life, even when I was really kind of young. And which turned out to be Lyme, but that's a whole other story. But Bactrim would help for a period, and then it would come back. And I kind of had this thing my whole life. And one day I took a Bactrim and my mouth swelled up and my eye swelled shut. And I called my pharmacist. I was like in my early 20s. And I said, hey, I'm not sure what's going on. And he's like, where are you? I told him where I was. He goes, oh, you're right near NYU. Tell them I sent you. Go to the emergency room right now at this very second and let them know I told you to go. Like, I said, oh God, this is bad. So I did have a pretty pretty terrible reaction. So after that, I was really afraid that that was going to happen again because I did feel like I may have died. If he didn't tell me to go, I felt like my life was actually in danger from that response. And for years, I did have an allergist at that time who told me you're going to have to carry an EpiPen for the rest of your life because allergies are wily, they're unpredictable. And we don't know if you're going to have this again now to something else. Honestly, it was terrifying. And I can't imagine having alpha-gal and having this constant fear hanging over me about food. It's scary. Do you have a lot of patients tell you, I'm really traumatized by this?
I do. And I think I'm glad you brought that up because I think it's probably one of the most important points in all of this is the mental health aspect, the post-traumatic aspect, as you mentioned. It's probably apart from the diagnosis and being uncertain perhaps about what they should avoid and how deep to go on the food allergy side, that the mental health part of having these allergic reactions, and I think particularly the delayed aspect
Yes.
where you just because you ate dinner out and you left the restaurant doesn't mean you successfully avoided. And
I
so
know.
it comes up a lot. And I think and I put myself in this space too, like we don't talk about it enough as allergists. We need more specifically trained mental health practitioners to help us on this food allergy side. And I think we have known this about food allergy in terms of the anxiety and panic part of that and the PTSD part of that for kiddos for years. I feel like we explore this with our kids, and we try to reassure them that having some anxiety around what you eat is a natural part of having a food allergy, and that we can deal with it. And even the studies show that actually people who are treated for mental health diagnoses, if they have food allergy, their mental health is better around this because it's being addressed. And
Interesting.
so by not addressing it, we're really leaving patients in a spot where they don't have help. And now with AGS, we have these adult patients with a new onset food allergy, and I really think they're not getting the mental health care that they need. So when you look at study after study in the food allergy space, the things that come up are panic and anxiety around the reactions and the exposures to food, and not knowing that whether something is safe or not.
Yeah.
And you'll have patients who will say, look, the social aspect of eating has totally changed for me. So much of what we do in the US and Europe, for that matter, revolves around eating and the socialization of that. And for me, a meal is a risk, and it's hard to relax in that space. I think we really have to talk about it and give resources for our patients to be able to have that aspect addressed.
Are there resources currently? Are there alpha-gal support groups that are online, or people that meet and get together?
Yeah, there are support groups online through various of the social media aspects and avenues. But to my knowledge, there's not a real formal kind of mental health diagnosis around food allergy.
Right.
It feels
Right.
to me like we probably should actually have that, because you can imagine, right? If you've had anaphylaxis after eating something, when the next reaction develops, you don't know if the itchy palms and the hives and the GI upset are leading you back to an anaphylactic reaction, or if maybe it's just going to stop at that. And I think,
Do people have to always also go seek care? I understand you're saying you need to carry an EpiPen and stuff. Is that the treatment? Or do you go, oh gosh, here it comes. I have to go to urgent care. I have to go over to the ER.
well, epinephrine is the treatment for anaphylaxis. And, seeking care in the setting of an allergic reaction is certainly reasonable, and probably merits like a individual kind of discussion and depends on a lot of different factors. But
Sure.
certainly we want people to think about epinephrine as really the treatment that should be prescribed and undertaken for anaphylaxis.
Do you need one shot normally? Or I'm asking because I actually have a friend that required for a different anaphylactic reaction, but multiple shots of epinephrine. Is that common?
Fortunately, it's not common. It does happen. I mean, we have patients who will come to us after having been in the ICU, placed on an epinephrine drip. So
Wow.
there are these severe cases. Fortunately, they're uncommon, if not rare. In the overwhelming majority of instances, a single dose of epinephrine is sufficient to settle the allergic reaction.
That's great. And I'm not sure if I directly asked you this, does the pre-medication, taking the Claritin or the Cromolyn, you said, prior to eating, your birthday dinner or whatever, does that actually mitigate the risk of a later flare?
Well, there's really no clinical trial data around that.
Mm-hmm.
I think anecdotally,
Mm-hmm.
what I hear from patients is that they probably feel as though if they've done that, that has helped. But it's hard to say because they're still
Yeah,
practicing an avoidance diet. I think it's just that little added layer of security.
it makes sense. I mean, intuitively, it makes sense. Any parting words, anything important that I didn't ask you that you want to talk about before we go? And of course, I want to know where people can find you and more information about you and your work.
Yeah, I think, we've covered a lot. One of the things that has come up frequently of late is this idea where people get a tick bite and have a tick panel of blood work done. And I just want to say from the allergy standpoint, that's not how we envision allergy testing being used. And the reason for that is there there's a high false positive rate with allergy blood tests in general.
Hmm.
And the alpha-gal test is not immune to that. So when we look in the case control study that I mentioned with the CDC, which was performed both in the UNC Allergy Clinic and enrolled controls from a rural county just south of the university, 30% of our controls, and keep in mind, to be a control, you had to answer that you both consumed red meat and had no reactions that you could attribute to red meat, over years. And we asked specifically about nighttime things. And we really vetted these controls because we wanted people who were truly negative. And 30% of them tested positive by blood test to alpha-gal allergy.
Wow. Wow.
So we know that in a rural setting in the Lone Star tick territory, there is a high false positive rate, probably just because people are getting tick bites. So we don't want people starting this avoidance diet just because they've had a positive blood test. You really want symptoms to drive the testing. So I think that's an important point. I don't want people just requesting a test because they've had a tick bite, because then there's a high chance you could be thrust into this allergy avoidance world, given an epinephrine prescription when you may just be a false positive. So
That is great information to have. So
that's
what is the best way to get diagnosed, I guess, is the question.
really we like symptoms or concern for symptoms to drive the testing, meaning people might notice that they've had an episode of hives in the middle of the night, or some unexplained gastrointestinal distress, maybe some itching of their palms, right? Maybe they had a tick bite like you mentioned earlier, where it was really slow to heal and it was itchy for a long time. And now I've got these new symptoms that I can't trace it specifically to a food, but something feels like it's changed recently. In those scenarios, I think it's a great use of the alpha-gal blood test to try to understand, like, oh, could this be what has happened? As opposed to, I had a tick bite and now I want to get tested for a panel of stuff. We don't like the allergy food tests used in that same way. Like, you wouldn't test a group of third graders for peanut, milk, egg, tree nut unless they were having symptoms of consuming those. So it's just a weird nuance in the allergy field with our blood tests.
I think that's an extremely important point, because I can understand the concern, especially parents worrying about their kids. Also, maybe their kids are a little bit allergic to begin with, and there's a concern and a fear about it. So we shouldn't assume everybody that has that test is really going to react.
Absolutely.
So what about what you have on your horizon and where we can find? I mean, you have some great talks and Q&As on YouTube, so people should definitely search your name and find those. But what else can we find about you?
We're really trying to curate some of the talks and presentations, and I think for me, the next step in this is really to to solidify some of that into a website. And then equally, we're hoping to establish and launch a podcast to help provide information and awareness and education for not only the general public, but hopefully for practitioners and providers as well. So I hope to have both the website and the podcast available within the next several months.
That's fabulous. Well, will you let me know when you do so I can share it with the Lyme community and get other doctors to share it, because there's such great interest in your work. Thank you so, so much for your time. You're so generous and you're such a great communicator.
Well, my pleasure. Thank you so much for the opportunity. And I really enjoyed chatting with you.
Thank you for joining us for this episode of Tick-Tective, a program of the Bay Area Lyme Foundation. For more information or to get involved, please visit us at bayarealyme.org.